DC team. Ehsan,
Thank you
thanks
so
for
much,
joining
Dr.
us
Snoop.
all the way from Egypt. Hopefully it's
Thank you, Dr.
not
Kawi.
too late for you.
No, it's fine. It's still like 9 p.m. in here.
Okay. All right.
Yeah.
Go ahead.
Sounds great. Thank you so much for the invitation. I'm just talking about because the presentation. Thank you. Wait 1 second. Alrighty. Hello, everyone. Good afternoon. My name is Ahmad. I'm with.
Oh, I'm Maddie Urso. I'm a second year CDU student.
Hello, and Hassan as well, all the way from Cairo.
Hello, everyone. Nice to see you all.
Hello. And as Dr. Shnood mentioned, we were privileged enough to be part of the team working with the with HIS unit, with the Syrian group in helping develop their mortality surveillance project. And today what we want to do really is to give you a very, very brief overview of CRVS, verbal autopsy. I know you guys had some meetings on it and already talked about it today, but just a very quick overview of it. And then we'll jump into what I think really is the meat of our presentation, which is our experience in developing or helping at least develop a mortality surveillance project in Northwest Syria. And so our goal for the next about 30 minutes is to really kind of explain CRVS, especially within the context of low and middle income countries, and the role of verbal autopsy in helping gather cause of death data, especially in regions without CRVS or incomplete CRVS, as well as our work through our organization, Make Deaths Count. And again, this is just the outline for today. So beginning with central registration vital statistics systems, essentially, you know, how I think about it, sometimes CRVS in my mind is kind of divided up into two things, central registration and vital statistics. And with regards to central registration, according to the UN, it is the continuous, permanent, compulsory, and universal recording of the occurrence and characteristics of vital events, such as live births, deaths, fetal deaths, marriages, divorces, and so on, and other civil status events pertaining to the population as provided by decree, law, or regulation in accordance with legal requirements in each country. So essentially, all of these vital events are recorded in the central registration. And of course, our particular interest here is with regards to those of the deaths. And so, though that is our focus, it's important to realize that, you know, civil registration has far-reaching implications, especially in granting individuals formal legal status, which really allows them to access certain services such as healthcare, education, and financial services. And this is very important because depending on the laws of certain countries, one may not be able to provide or have access to certain care without having legal status, without having, for example, documentation of birth certificates, so on and so forth. So CRVS may play even a more important role in different countries. And now with regards to vital statistics, and so central registration or civil registration, that is the collection of these data points essentially. And when you compile that information into statistical information, when you start making sense of it, that is the vital statistics part of it. And so this is really just the flow of the information. You have that registration system in place. You then create a database of all that information, and then you are able to use the vital statistics from that to then build on it certain policy decisions and certain public health initiatives. Great. So the importance, I know, you know, we've been belaboring this point as of now, but really, it's very useful for gathering information regarding births and deaths. And that's important because it helps give the government an idea of what the size and age distribution of the population is. You can think of this in a different, similar manner as the census that we have here in the US every 10 years. It also gives us information with regards to how many, where, and what people are dying from. And all of that, you know, hopefully we use that information to be able to plan these sort of like essential services, right? These public health initiatives based on this data or evidence-based implementation. And finally, having these accurate representative records allows us to build this information. And we'll talk in a little bit about the kind of the drawbacks of having incomplete CRVS, where you're only getting information from a limited set of society or your population. And so some of the challenges, right? I'll speak for myself, at least, CRVS is really not something that I think about or thought of before this work. Something I've certainly took for granted. Like, of course, every live birth is documented, or every death is documented, at least here in the US or other high-income countries. But as I'm sure you're all aware, is that in many low and middle income countries, this is not the case. Whether they have incomplete CRVS, which is likely the situation, or in some regions where there's incomplete or rather non-existent CRVS. And so the problem with that is obviously we don't have that information, but also if there is some CRVS, we're collecting very little information from a small number of the population. And that is actually not representative, because you're trying to use a very limited set of information and building upon it initiatives that are applied to a wider net of the population. And one other thing to mention before that as well is that one reason really that's contributing to these issues is that in many communities where these deaths are happening, they don't have physicians to be able to assign the causes of death, which is kind of like the traditional way of how these deaths are assigned. Either no physicians at all, or very little capacity to be able to handle the numbers of deaths that are occurring. And so many of those deaths go unregistered. And of course, this is what segues into the fact that verbal autopsy can be used to help mitigate this issue when you've had these deaths that have been unregistered. And before then, I wanted to show this flow diagram, because I think it helps to kind of visualize and give you context for how magnified this issue is really in low and middle income countries. So of all the deaths, only 10% occur in facilities, and that is usable for public health data. And of course, as I mentioned, if you're basing your initiatives or your policies just on 10% of the population, that is in itself problematic. But on the other hand, 90% are occurring outside of healthcare facilities, and that data is lost for many potential uses. And then without further ado.
Great. So for part two, I'm going to just recap what verbal autopsy actually is and how it's used. So what is it? It is a tool for determining individual causes of death and cause-specific mortality percentages in populations with incomplete CRVS. It really consists of doing interviews of families of the deceased, and one really main point is it's been shown to consistently outperform physicians in providing an accurate cause of death diagnosis, which is advantageous for regions with inadequate physician or supplies of physicians. And like the main, there we go. So the main components of the VA interview. So we have questions on any injuries, accidents that might have led to the death of the person. Any questions about like their signs or symptoms. So like, for example, if they died like COVID-19, we'd be like, oh, did you have shortness of breath, cough, and any symptoms like that. And then any questions on healthcare use and outcomes during terminal illness, and the examination of medical records and any death certificates that are available at the actual home. And then there's also a section that is the structured interview with the open history section. And the section really allows the person being interviewed to describe, like in their own words, any of the events that led up to the death that they are reporting on. And so there are three main uses for verbal autopsy. Obviously, as a research tool, you can use it in longitudinal studies, intervention research, epidemiological studies, as a cause of death data source, and as a method for monitoring any progress or evaluation. Yes.
Thank you so much.
There you go.
Alrighty. So now to really what I think is the most impactful part of this. And so out of the work that we've been doing with Dr. Schnood with Syria, we quickly realized that there's more work to be done in this area of mortality surveillance, helping them develop mortality surveillance in low and middle income countries. And that led to the inspiration for us to start our nonprofit organization, Make Deaths Count. And essentially what we do is we partner with these NGOs on the ground to help them develop mortality surveillance programs using verbal autopsy. And we really work with them from A to Z, walking them through that process. And just to give you some context really for where that inspiration came from. Well, one, we realized that nearly 50% of deaths in the world are unregistered, according to the WHO in 2017. And as I mentioned earlier, 90% of those deaths occur in low and middle income countries and therefore go unregistered. And obviously, decision makers lack this death data to being able to enact public health initiatives. And so what we also realized is that there's no entity that currently exists to address this in an easily and accessible manner. There are organizations out there that provide resources, but the resources are very difficult for any one organization to self-implement a verbal autopsy project. And especially it's important to keep in mind that these areas that have limited resources also have limited resources to be able to spend time and money on learning how to do verbal autopsy. And they need somebody to help them, just give them the actionable items, the actionable points, as well as understand their issues to just tell them how to get through it. And to give you an idea of kind of where the need, how much of a need this is, in 2040, it's projected that there will be about 160 million deaths annually worldwide, and about half of that, about 80 million, will go unreported. And so in our minds, we saw that the solution was to provide consulting services to global decision makers in low and middle income countries to help them develop mortality surveillance systems using verbal autopsy, which in turn will guide public health policy decisions with the ultimate goal of improving health outcomes for the most marginalized communities globally. And so to kind of recap, what we really tried to do and aim to do is to partner with ministries of health and NGOs to implement a survey-based program, which is really verbal autopsy, in providing local stakeholders with easily accessible and actionable information using machine learning algorithms. And what I really want to highlight is this accessible and actionable information. And so we do this really through consulting work with our partners. We provide training to our partners in how to develop a verbal autopsy, in training the community healthcare workers in actually doing the interviews and collecting the data. And at the end of all this, we help out in analyzing the data, where we then collect the data collected through the interviews and analyze and provide cause of death data to our partners. And finally, if there is interest, we can jointly publish on their work to get the word out there about the issues that are going on in the region. And just to give you an idea of how we intend to represent this information, this is kind of an overview of a data dashboard of what the of causes of death may be. So, for example, we can provide it by gender, we can provide the death information by location, by date, by age group, as well as here on the top is a snapshot of any information that is of particular relevance to our partners in those regions. For example, total cases or COVID-19 cases, or cases under 5 years old in children. And hopefully you can see that this information is quickly accessible to whomever our policy decision makers may be. We can also obviously provide causes of death, in this case, for example, by decreasing order. And here we have, as an example, COVID-19 is the overwhelming leading cause of death, followed by cardiovascular disease and neonatal disorders. So I can see at a quick snapshot is that I really should probably be putting my resources into vaccination programs, for example. And finally, if we have location-based data, we're able to provide this death heat map, right? So, for example, if we find that the highest causes of death are due to strokes, and I feel or see rather that strokes are very concentrated in this region in red, then as a decision maker, I might want to start thinking towards implementing and starting maybe clinics or hospitals that have stroke care in that region instead of putting it somewhere else that is not advantageous. And so, again, the impact of this, of having cause of death data, is one, the efficient allocation of financial resources. And this is even more so important to our partners because they have very limited resources. And so they want to be able to know where can we allocate our resources to get the most, to have the most impact in our communities. And again, you're able to develop all these public health initiatives based on this data, like vaccination programs, if it's like, let's say COVID-19 is the highest cause, or location of new healthcare facilities if it's due to stroke, or if we find that one of the highest causes of death are due to motor vehicle accidents, and maybe there should be an investment in civil infrastructure. And so from this, we want to kind of talk about a bit more specifically with regards to our experience in Northwest Syria.
Okay, thank you, Ahmed. So, like Ahmed said, and Dr. Kavi, our very first verbal autopsy project was in Northwest Syria, and it started when a Syrian nonprofit organization operating in Turkey with the name of Health Information System, or HIS, like Dr. Kavi mentioned, they approached Dr. Kavi and he recruited us to develop a mortality surveillance system in Northwest Syria. And it's a place with no governmental control and no means of capturing mortalities on the community level, and their chosen methodology for that was through verbal autopsy. So our very first step in this project was to identify the appropriate tool to be used for verbal autopsy. And at that time, we were debating between two tools. The first one is the WHO 2016 tool, which was not user-friendly as it required an average of 45 minutes to be completed. And the other one is the IHME tool, which was more person-friendly as it required around 35 minutes to be completed for the single interview. But unfortunately, it did not screen for COVID-19 as a cause of death. And that was obviously very important. So we tried to go through published research to see if there are any literature who used COVID-19 with the IHME, and we also, with the help of Dr. Kavi, we contacted Dr. Abraham Flaxman, who is one of the professors published the survey, but unfortunately our efforts did not pay off. And fortunately, the WHO released at that time the 2022 tool, and it was more user-friendly than the 2016 one, as it required around 25 minutes for the single interview. It also was a very enhanced tool because it got a lot of lessons learned from the previously published survey tools. The second step is that we spent almost 2 months compiling a training material from different resources for the interviewers, who are the individuals conducting the survey, and the supervisors, who are the individuals providing oversight and technical assistance. Following that, we had another debate about the sample size and sampling methodology. And even though the cluster sampling is the best methodology in this kind of setting and context, we agreed to go for the convenient sample, as that was the most appropriate sampling methodology in the Syrian context. So we started with 25 interviews as a pretest, just to check if there are any further training needs or modifications required. And then we agreed on 600 interviews to be done during the pilot phase. And then to allocate death cases, we had to identify the most appropriate reporting strategy in the Syrian context. And that our Syrian partners, they agreed that the best methodology for that was going to be through the community leaders. So the flow of information was going to be that the community leaders will allocate the household with a death case, and then he will inform the supervisor, who in turn is going to map out the households and the schedule for the visiting of the interviewers. Following that, we had to identify the community health workers who are the interviewers, and ideally they should be non-physicians and trusted members of the prospective community. And in this regard, we collaborated with another nonprofit organization operating in Northwest Syria, and they are the Physician Across Continents. And the organization had already several community health workers operating for them on another project in the same region. After that, and after defining all the main structural elements, we successfully won a $150K grant from the Bloomberg Vital Statistics to implement the pilot phase of the project, and they will deliver to our Syrian partners. After that, the first step of the implementation included us traveling to Gaziantep in Turkey on the Syrian borders, and is to deliver a 4-day training sessions in person to the supervisors, who in turn delivered that training virtually to the interviewers. And the training including discussion on CRVS, causes of death, coding, ethical training, sensitivity training, interviewers and supervisors' role, quality control of the interview, and possible challenges and role play. Directly after that, the interview process started, and so far the Syrian team reached 450 plus interviews out of the 600 target. Next slide, please. So through our project, we encountered several challenges, one of which that there was no specific, simple, and evident user-friendly training material available for verbal autopsy. So in order to prepare our training material, we had to go through numerous scattered resources to come up with a one simple 4-day training module that provide training from both practical and theoretical lens. The other challenge is that we also had to translate the VA survey to Arabic as it was only published in English from the WHO. So our Syrian partners translated the survey into Arabic, and also they had to remove some of the culturally inappropriate questions from the survey. And that happened after several meetings and discussions with WHO in order to make sure that we're not messing with the algorithm or the validity of the survey. And another challenge that we have is that the cultural aspect of the Northwest Syrian context doesn't accept that an interview to be done with a female through a male interviewer. So we agreed to send both a male and a female bear interviewers to each household instead of the recommended one interviewer per death case, just to come over this challenge. And another challenge was to preserve the confidentiality of the deceased and the interviewee. And in order to do that, it should be done ideally in a quiet and a separate room. However, some of the interviews were scheduled to be done in camps where confidentiality is very hard to attain. So the Syrian team decided that they will do that in a separate tent for just to try to preserve the confidentiality of the interview process whenever possible. Next slide. So the key element to overcome or reduce the impact of these challenges was to rely on our Syrian partners because they are the ones who are most knowledgeable about the facilitators and hindering factors that might affect the progress of our project. Next slide, please. So this experience inspired us to mimic this project in other regions of the world in dire need of such initiatives. And currently we have an agreement with organizations from Somalia, Colombia, and India, and they are very enthusiastic about this project. Next slide, please. So another project that we are currently working on is developing a social autopsy survey. And social autopsy is a related method that focuses on social and health system determinants of outcomes, providing supplementary information to that on medical causes of death. A combination between VA and SA can assess in identifying gaps in vital statistics, facilitating burden of disease estimation, identifying priority settings, and providing a foundation for benchmarking and planning, all to improve the health system into functioning more effectively. So social autopsy is generally like getting information about the social determinants and the social background. When added to the medical causes of death, it can provide a wholesome view on the mortality inside the region. And currently we are collaborating with someone from India who had her PhD in social autopsy just to help us develop and validate a social autopsy survey. Next slide, please. So this is my teammates and I with our inspiration to help countries in need to develop a CRVS system. Next slide, please. So if you would like to know more information about our organization, we urge you to visit our website or through our LinkedIn page, or feel free to email us on any of our mentioned emails. Thank you for your time and thank you for listening, and we're open for any questions you might have.
Thank you so much. So this team, as you can tell, they are social entrepreneurs. They picked a very specific topic, which, as they mentioned, has not received the kind of attention it deserves. How to support ministries of health or humanitarian organizations to improve mortality data, number of deaths, cause of death in these humanitarian crises. And there really isn't a nonprofit out there that's supporting the ministry. So I think it's quite an entrepreneurial experience. Let me just open it up. People can raise questions, any comments they have. Savannah?
Hi, that was great. Thank you so much for presenting. So I had a question in terms of the verbal autopsies. I'm curious if you faced any significant pushback or limitations associated with family members not disclosing manner and cause of death due to stigma. And if you did, how did you navigate those situations or cultural implications?
Certainly. Thank you so much, Savannah. Well, to kind of backtrack, we tried to avoid these pushbacks on the surveys by, first of all, relying on community leaders to help connect the community healthcare workers who are doing the interviews with the families that were to be interviewed. So we kind of had that agreement going in before the interviews. But even then, there have been people who have pushed back a little bit, but really from what we've been training and what we've learned doing this process is that, if there's pushback, that's fine. Just move on to the next question. There is no need to really try to get to not be on good terms with the families, because this is a very sensitive period. And so the information is what's most important for us to get. But there has been some pushback, but we've really been relying on the local community who know these families well to avoid any of these kind of problems to arise.
To add something, we actually had this conversation relating to suicide, because suicide there is a big stigma around suicide in the Middle East, and our methodology just to come over that was how to choose the community health workers. So as I said, it should be trusted members of the community, so they can trust him or her, like to give them this sensitive information and at the same time protect them against the stigma in the community.
Great. Thank you so much.
Abby, do you see the
Sydney?
Go ahead.
Yeah, I wanted to ask, there's so many different diseases that their symptoms are non-specific. So I guess, there's things that seem difficult to do without having some kind of way of doing any kind of test. So I didn't know how, if you want to intervene in some kind of like outbreak setting, I guess, how do you go about dealing with like diarrheal diseases where it's really non-specific symptoms? And if you want to have an intervention that works, you kind of need more than just know like those kinds of things.
Absolutely. Lovely question. Very important. So it's important we kind of couldn't include because of our presentation would be very long, but the important thing is to understand what causes of deaths are included in verbal autopsy. And that goes into kind of doing that kind of homework before using it. Because verbal autopsy only includes causes of death that it can ascertain with a very high sensitivity and specificity. Otherwise, it is not included because obviously, as you correctly mentioned, there are diseases that you need more than just essentially questions to be able to ascertain it. You need lab data, you need imaging, you need pathology reports to be able to assess it, which obviously we're not doing. And so those illnesses or diseases are not included in the verbal autopsy list of causes of disease. And so it's kind of important before implementing it and using it to go through that list. And we can show you that list as well of what is included before really trying to say, well, I really wanted to know what kind of diarrheal disease this was. But, in general, it can tell you, things such as malaria, or it can tell you things like cardiovascular disease, heart attacks, pneumonia, so on and so forth.
Thank you.
You're welcome. Brandon.
Thanks so much for the presentation. On one of your slides, you mentioned that you partner with ministries of health and NGOs for training. And I'm wondering if you could talk a little bit more about how you establish relationships with ministries of health as a relatively small student or recent graduate-led organization. How do you legitimize yourself to a federal government? How do you think about providing policy recommendations or trainings to people who are professionals in the space? How do you kind of balance the sensitivities of that relationship?
That's an amazing question. So yes, we are very recent. We're very new. We just graduated. That is true. But the important thing is that we know ourselves very well. We know what we're good at, and we know what we do and what we don't do. We know how to develop verbal autopsy trainings. And we really tell our partners, NGOs and ministries of health, that we serve as a supportive role. We're not going into the regions to do the training ourselves. We're not bringing people there to do the trainings. We are only there to help them in the event that they actually do want to develop a verbal autopsy program by doing these trainings, by helping provide the data analysis. And we, thankfully, through the work that we've done in Northwest Syria, which is a particularly difficult region, as Hassan has mentioned, the challenges there. And so in other regions where it's a lot more stable, they can understand, well, if we've had that experience, then it should be transferable to their region. And on top of that, working with NGOs is a little easier, I would say, than working directly with ministries of health. But then again, we work through our partners. We've presented at multiple conferences and have had the pleasure of having people come up to us and say, hey, like, I used to work in the Ministry of Health, or I know people in the Ministry of Health. I want to introduce you, or I want to be the connection between your organization and the ministry. And so that's kind of how we get that buy-in, because they have that relationship. And frankly, we have that legitimacy through them to the ministries of health.
Yeah.
If anybody wants to add anything else, but I think that's essentially what it is. And honestly, also, we rely on a lot of the Yale connections to the Yale network. I mean, they've been amazing, especially Dr. Shnood, who's been absolutely instrumental in just connecting us with different partners and different people through the work that we've been doing. Thank you, Brandon. Min.
Hi, yeah, thank you for the presentation and also for the work that you're doing.
Appreciate
it. I guess I just wanted to ask a little bit more about the sensitivity training and what that looks like. Like, these people with their questionnaires, they're essentially recounting, the death of their loved ones and like the people closest to them. And I was just wondering what that would look like specifically.
I think SM can continue.
Yeah. So sensitivity training is basically a scenarios on what to do when the family of the deceased is angry, is sad, doesn't want to talk right now. So we deliver a training through role play. At first, like we gave them a lot of information about possible encounters and the challenges that they might face during the interview. And then we gave them some information on or guidance on how to deal with the situation if the family is like crying or angry or cannot respond to the interview right now. So it was all like a role play on how they can do that. And of course, the experience of the healthcare workers in Northwest Syria and doing previous interviews gave them a privilege on how to deal with these situations. Ahmed?
I see. Thank you.
You're welcome.
That's it. Great. Any other questions? I will take this opportunity to very quickly share this. All right, 1 second. That's very sorry. I'm sorry, I don't know what I'm doing. Just give me 1 second. Here we are. No. Okay, here we go. So just very, very briefly, with regards to the causes of death. So there are 12 categories that are included in the verbal autopsy. And again, it cannot ascertain all causes of death. Hence, there are many that are not included, and only those with high sensitivity and specificity. And even those that are included, not all perform equally in terms of their likelihood, but still very high to be able to base decisions on it. And so, for example, one category are infections and parasitic diseases. And you can see here things like sepsis, malaria, measles, tetanus, and just recently in purple here, COVID-19. And one important thing to mention is that the algorithm, the machine learning algorithm that uses this data to be able to produce causes of death will, one, try to ascertain the cause of death as, let's say, an infectious disease. But if it feels that it does not neatly fit into any one of these, it can still say unspecified infectious disease if it still feels that it is of an infectious nature. However, if it still doesn't fit into any of that, then it says it's a undetermined cause of death overall. And you have things such as neoplasms, nutritional and endocrine disorders. And you can see there's some categories that only have 1, 2, or 3 causes of death. Disease of the circulatory system, cardiac disease, stroke, sickle cell, respiratory disorders, COPD and asthma, GI disorders, acute abdomen and liver cirrhosis, renal disorders, only 1, just renal failure overall. Epilepsy, only 1 in mental nervous system disorders, and a whole host for pregnancy, child related disorders, as well as neonatal causes of death, stillbirths, and finally external causes of death. And again, in purple here is that cause of death unknown just doesn't fit into any of these categories. And so it's important for somebody who's trying to implement verbal autopsies to actually take a look at this list beforehand. And that's kind of what we really try to do with our partners is, let's take a look at this list, and do you feel that what you're hoping to look for is not included? That may not be the best route. Or they're just like, well, I just want to have some data. I don't have any data at all in this region. And I would love to have better data to implement whatever decision they want to do. So just thought this would be helpful to give you a better idea. Right. Any other questions? You're certainly welcome, Sydney. And we'll provide the slides to Dr. Oshnud afterwards so you can circulate it.
All right.
This is so cool. Just wanted. Oh, sorry. Go ahead.
No, you
Just
go
wanted
ahead.
to-
Oh yeah, if you guys
so
think it's cool, just
cool.
let us know too. Like,
Yeah.
we're not
This
above
is
that.
so cool.
It
Oh
is.
yeah.
It is. I think it's a very
Thank you for sharing with us.
It's a very concrete example of what you all can do, honestly. Like these were Ahmad and Ehsan were students when they got interested in this topic, and they're doing it and they're starting to get attention. I just shared with you that YSPH just did a story about them. The Sci-City, some of you know Sci-City is like the entrepreneurial hub umbrella at Yale. They're being recognized by them as a very innovative approach to trying to solve a very, very important global health problem. And hopefully they will start getting more and more attention from potential funders, because this is a massive, massive topic and requires a lot of support. But again, the good news is it is possible to do things, even how, the level of complication. So I really want to thank this amazing work you've been doing. Thank you so much.
And if anybody would like to, sorry, Dr. Oshnud, I'm just gonna, it's my one and only opportunity. If anybody would like to support the work or be involved, if you have a vision for anything, we are more than happy to,
I'm glad you mentioned that, because they've actually approached our faculty, and I believe that there's potential for doing internship with them. There's potential for doing a practicum course, like an independent practicum course.
Yes, we currently have the practicum available for this semester.
Right, so that was approved by the committee. They looked at what they're doing, and they said that if there's a student who wants to do a global health, like a practicum course with the Make Deaths Count, that's appropriate. They can do that. So if you have an interest in this topic, feel free to reach out to the team and have a conversation with them. Wonderful. Thank you so much, everybody.